Hello, everybody. Thank you for the invitation. I'm going to speak about two things. I'm going to speak about seniors in the community, and I'm going to talk about a provincial approach to wellbeing over the next 20-25 minutes. And I'm hoping to leave time for questions. So I'm sure you're all aware that the population of the province has changed radically over the last 50 years. And now we've got 23% of our community, of our people are over the age of 65. And many communities over 30% are over the age of 65. And that's going to continue to increase. And on top of that, there's increased migration from rural communities to urban communities. And the current health system is probably no longer suitable for today's population, particularly as the number of people who are, number of seniors has gone up so high. So a quarter of our population of seniors are considered to be frail. And then the prevalence of frailty in acute care in this province is higher than the national average, with 80% of individuals over 65 who are admitted to hospital being vulnerable or frail. And frail elderly people are the highest users of acute care. And 20% of all our acute care beds are occupied by people who do not require the intensity of services that are actually provided. So we do have, from the perspective of the capacity of our healthcare system to deliver, we have elderly who could be better prepared to be able to survive the pressures that come upon them when they come into hospital. So the Health Accord took this agenda on board of trying to improve the health of seniors. And we identified 6 areas. One was the culture of ageism. In other words, that elderly people are not valued by the community. And that came through time and time again when we interviewed groups of people responsible for seniors. That we needed age-friendly communities and that we needed to encourage aging in place. And by that, we didn't necessarily mean that it was aging in the home that they lived in. It might be some other area, but that in the community that they lived in. And that we had to develop an integrated continuum of care from being frail, living in the community, to requiring long-term care and to being looked after in the acute care hospital. And one of the things that we really identified as being critically deficient in our province was comprehensive seniors care from the community to the hospital. And then we identified that there was legislation necessary to protect the rights of seniors. As a consequence, this is what we said: implement and support an integrated continuum of care to improve the effectiveness and efficiency of acute care, improve health and social outcomes for older people and older adults with disabilities, and support older adults to age in place with dignity and autonomy. And then we also said, take immediate steps to identify and respond to the ageism in our province, including the support for the development of age-friendly communities that enable Newfoundlanders and Labradorians to age positively. Now, the piece that's directly relevant to this group is the whole concept of age-friendly communities. And I might add that within government, there is now a cross-departmental group of deputy ministers and cross-departmental group of ministers who are discussing these elements and trying to develop an environment that these policies are passed and funded and can be acted upon in the community. So an age-friendly community is a community where the policies, services, and physical spaces are universally designed to enable people of all ages to actively age in a secure and accessible environment from both a physical and a social perspective. In an age-friendly community, seniors are supported to age actively, enjoy good health, and remain independent and involved in their communities. People of all ages and abilities benefit from safer, barrier-free buildings and streets, better access to local businesses and facilities, and more green spaces. Business benefits from the accrete support and spending power of older customers and are better able to support older workers. And the community benefits from the increased participation of older adults in community life. And we've been told frequently that people would retire and they had the capacity to contribute to their community, and they were inhibited from doing it by policy, not from their desire to contribute. So what do we mean by age-friendly communities? So this is adapted from the World Health Organization, or adapted, I mean. So it includes the following 8 elements: transportation, and we hear a lot about rural communities that transportation is a massive, massive issue. Respect and social inclusion, communication and information, outdoor spaces and buildings, community support and health services, social participation, civic participation and employment, and housing. They're the 8 elements that a community should try and have an impact upon. So let's just now talk about ageism. It's defined as prejudice or discrimination on the grounds of a person's age. It is often systemic, and it can appear in multiple areas of everyday life and includes discriminatory practices in retail, marketing, the workplace, healthcare, and social programming, etc. And certainly when I was working in healthcare, you could actually see that the elderly people were prejudged to be sick and frail and not have a good outcome. This discrimination can have serious negative impacts on an individual's well-being and can directly impact their health. So the interventions offered through age-friendly community programming can help make the shift, because for sure ageism is harmful, and it can be combated through policy and law, educational activities, and in particular, the one that I'm most attracted by is intergenerational interventions, particularly grandchildren interacting with their grandparents. Now, so this is the kind of diagram that we produced in terms of the continuum of care, that it moved from the home to the community team, these family care teams we're talking about, to personal care homes and long-term care, to the community hospitals, and then on to the regional hospitals and the tertiary hospitals. And age-friendly communities can play a big role in the aging in place agenda. And the whole idea of being able to prevent frailty and manage frailty can be helped enormously by having age-friendly communities. So what do we mean by aging in place? So aging in place in age-friendly communities becomes the foundation for care for older people in their homes, in personal care homes and long-term care facilities. And the idea that when a person goes into a long-term care facility that are now divorced from the community is false. The community teams that we're talking about, they permeate all components of the elder care system. They've been rebranded as family care teams. The age-friendly communities would be enhanced by action in those 8 domains that I outlined earlier. Now, so that's the kind of background to the aging in place and the age-friendly communities and the relevance to municipalities and communities. I'm going to switch now to a second subject that's kind of related. So we are particularly interested in a provincial approach to well-being that permeates society. And really, the reason for that is that we want to increase not only the awareness, but take action on the social determinants of health and disease risk factors that impact our health and well-being. And let me give you the reason why this is important. And it's more important than what we do about the healthcare system, even though people don't believe that. So here's the diagram that I think we should all take home. So this is what makes Canadians sick. And what it demonstrates there, that 50% of what makes Canadians sick is stuff to do with your life. How you grew up, where you live, what you worked at, what your status is, Aboriginal status in particular, who are disadvantaged enormously, your home, your home, your food, and your income security. They matter more than the healthcare. And you can see that the contribution to what makes Canadians sick, 25% is attributed to your healthcare. And the other piece that you should add in there is the 10% for the environment, such as air quality, unboiled water, civic infrastructure, etc. So you can see from that 60% is driven by the social determinants of health. So what the Health Accord identified was these are the areas that we needed to intervene in. How we live, which is economic security, a livable basic income, food and housing security, income support. The second was where we live, particularly addressing the climate emergency, awareness and education, reducing our environmental footprint, and examining the health impact of climate change. And then how we relate to each other, inclusion, one inclusive society. And the message that we got time and time again, that we had to meet people where they are, that there should be zero tolerance on racism and exclusion, and we needed a new inclusion lens that stated nothing about us without us. And the other really important area that's driven by the evidence is we need to invest in our future, particularly in early childhood and youth, through the Healthy Students, Healthy Schools model, through a more integrated child health model, and through models of care for children at risk. Now, you mightn't have heard us use the term well-being as bringing meaning to the social determinants of health, which is a kind of an academic term, but it's a term that's used in other countries, and it brings together issues that are more academic, like health in all policies. That will be something that will be, what would I say, evolved out to the municipalities over the next year, that we should consider all our policies with a health lens. The social determinants of health is another component of it. And then you've got the component of population health, which is really an effort to decrease disease risk within communities. And they're all brought together by using this term well-being. New Zealand has a well-being budget. Scotland has a well-being account. Iceland has well-being. Wales has got well-being legislation. And we want to take a provincial approach to well-being. The three big things that we've identified from looking at the data are preventing childhood poverty, increasing the number of people that can leave high school, and promoting health by decreasing disease risk. And let's face the facts about poverty in the economy, because poverty equals ill health. It's very expensive. There's big public spending on consequences, not causes. And child poverty is unjust. Its economic and financial costs last a lifetime. And intervening can lead to very substantial benefit. And then on top of that, economic development is dependent on a healthy society, and a healthy society is dependent on economic development. So approaching the prevention of childhood poverty is very important. And you can see here that in our province that we are spending on health care has gone up by 232% in about 40 years. Whereas our in Canada, the increase in health spending has gone up 100%. But when you look at social spending, we've been flat, 6% in 40 years. Canada is not much better, 32% increase in 40 years. So our focus on well-being means that we need a central objective for government and municipalities of targeting well-being within the population, because my own belief is that politics is not so much as about generating money or generating a good finance department. politics or generating money is about improving the well-being of our society. So we need to support the population health, the public health agenda. We need to align it with a health in all policies approach. We need to develop a framework to inform a process for decision making. We need to determine our priorities and coordinate them. And a successful approach requires integration across not only departments, but the rest of society. And by that I mean we need to ensure that we've got community engagement if we want to have any traction in this arena. So we have a proposed structure to align with well-being. I'm not going to go into it in much detail, but it does involve a government structure that works across departments and aligns in policy. It involves a central kind of well-being secretariat. It involves working groups that can evaluate impact, and it involves working groups that would promote health in the communities. And it involves linkage to these well-being networks that are just outlined there on the right-hand side. I guess we do. So this graph kind of gives you an idea of what we mean by a well-being network. We see these as being regionally based, initially 5 or 6 networks, populated by people responsible for those things that are necessary for well-being, good health, good social system, good education, municipal input, indigenous input, etc. And that it would be populated by staff that would allow these networks to function properly in trying to do 2 things. One would be identify what are the major things that are occurring in their region from a social perspective that are causing problems, and determining solutions for those problems, that being one. And then the second being able to provide feedback to the decision makers in government about whether or not their policies are actually working for the regions. So we see that as a 2-way street. And we hope to embark on starting off these networks soon. And then besides that, kind of bilateral connection between the center and the periphery, there's also a need to have a connection with the Provincial Health Authority, because the Provincial Health Authority has 20,000 workers and they're in every single region, and they have an interest, they should have an interest in this well-being agenda, because the whole interest is to prevent disease and to prevent people going into hospitals. We plan to have a provincial week of well-being in September, where we're trying to have events that are in schools where the children are, as you can imagine, in the workplace, linked to the unions, the government, the university, etc., and with information coming from the people who know something about this agenda, like the health system, the social system, the educational system, and amplify it through all those people who've got social connections, politicians, people working in the health system, unions, etc. And if you can use that amplification power, we would hope that we'd get improved awareness of what healthy living means, and what actions are going to be taken on the social determinants of health. And we see this, I'm not going to go into much detail here, but we see this as being having a big connection to communities and municipalities. Because one of the things we know, the evidence tells us that the sense of belonging to the community and pride of place is the strongest in Canada, in this province. That we need to reach high-risk populations, and that really can only be done through the communities. And we need to get community champions. And then the other areas that we're going to focus on is schools, the workplace, recreation and sport, tourism, and arts and culture. And the thing that you might not think is that culture has a huge impact on well-being, particularly when we think of mindfulness and reducing stress, and also in using the resources that we've currently got to help our residents, parks and trails, etc., where we're selling the parks and trails to tourists based on a mindfulness agenda. We should be selling it to our residents based on a mindfulness agenda. So I'll stop there and take any questions, Amy. I don't want to be asking myself questions now.
Yes, you spoke about making connections with government and schools and health agencies and all that sort of thing for age-related initiatives. If you haven't already, you might want to consider adding to the list the network of 50+ clubs that are across our province. Would be a good contact point for some of the things that you've mentioned.
Yes, they've definitely been involved in all the discussions that have been ongoing. There's been representation on the health accord from that particular group, and they're consistently in communication with the elderly agenda that we're trying to go through with the ministerial departments, etc.
Good day. Triffy Parsons here. Of course, I got to get up to the mic. We've done a lot of work actually with our seniors in the areas, but what we're finding is transportation ends up being an issue. So our buildings are accessible, but it's getting them there. So will there be a component involved in this where you can actually get them to the events? We handed out food hampers a while back, and we're really, really surprised by the number of residents that were in need when it came to that. And now our neighboring community is actually doing meals every couple of weeks through a funding proposition. But as everything, every time we turn around and do something, we need help. And getting some sort of transportation system to move seniors to the events, it would be a big thing if you can get that as part of the wellness.
You're dead right. And I think that the feedback we've received, an enormous amount of feedback, is that transportation is the biggest issue. And in particularly in rural communities, and how to organize that type of transportation, which is probably more dependent on communities and community involvement than it is on the public system, which is easy to evolve in cities, etc. So it is a challenge, and it's something that's been discussed about how you can enhance the transportation, particularly in your rural areas.
Hi, my name is Glennis Pinney. I'm from the town of Port Hope Simpson. My question is concerning like the seniors. I'm not good at this, but it's a day that I'm very emotional because my mom is in the senior long-term care in Port Hope. And we had to move her there because there was no one that could take care of her needs at the time. She's got dementia. And that area from Fordo to Penson's Arm, we have a large family. And we're going constantly. Every day there's somebody there to visit her. We hired somebody to put into long-term care because there wasn't enough staff there. We figured because she wasn't getting the care that we needed for her, or so they said, and they were going to move her. But we said, no, there's nowhere where we can move her. There's nowhere on the South Coast. We had to move her out of her own community. And that was very, very hard on her. Dementia people, as you all know, like surroundings, familiar surroundings and familiar faces. And mom became very, very good where she was, and we didn't want her to move her. Yesterday, the family was traveling everywhere. We were all on the highway. We got this chat on our phones, and we were all screaming and crying in the car because they flew a plane into Blancablan to pick my mom up and bring her to Goose Bay, which is like over 800 to 1,300 kilometers away from each one of us. And that's a return trip now. And we just didn't know what to do. We got out, I guess, to your office. We got out to MHA. She got out to the minister, and they told the plane to stand down for a day. So we're still in limbo. We don't know. Like, our communities on the South Coast don't have that type of care that she needs. So I don't know why she had to go to Goose Bay. She's still in Fordo right now, waiting to see what's going to happen. So my question is like, what can we do for seniors that that we can keep them at home, that we can keep them in our own areas. And when you start to talk about that, it made me very emotional because that is exactly what we're going through.
Right. So there is little doubt that we have major deficits in our capacity to age at home or age in place as we are recommending. And the more isolated the communities are, the less we're able to do. And it's a lot of the care at home is delivered by private agencies. And those private agencies only work because they have a population that can actually pay for their services. So one of the issues, which is without a doubt an issue in Labrador in particular, is the capacity to be able to hire home care workers who are capable of doing the job you're talking about and be able to fund them from the public purse. And that is that's a policy decision that would have to be made by government. But the solutions to home first types of things are important and are certainly being discussed at the present moment. I think that we're all entirely aware that our spending on seniors is radically different from our spending on children, and that we have a total need to be able to provide better care for seniors, particularly to keep them in the community.
Our community has like probably about 70% that are over 60. We don't have a big population of young people. I don't know, like our homes are not fitted out for like our whole family. Got houses that are like 3 and 4 levels, and that's not convenient for somebody that's got dementia.
Yeah.
So it's very difficult to, and we figures if she goes into Goose Bay, we won't see her anymore.
Right. Well, there's nothing attractive about getting old. I'm beginning to discover myself.
No, I just felt like, oh, we need better housing or something in our smaller areas that can accommodate people who are getting older. Like, I know it's not going to affect my mom right now, but it can affect some of the ones that's like a little younger than my mom.
Yeah.
Hi there, Rosetta Parsons, Woody Point Council. I was wondering if there is any allowance for family members to care for elderly?
You got to remember, no, I'm not a bureaucrat. Well, I am, I suppose, but I'm not. I'm only a bureaucrat to try and help him implement the health accord, and I don't really have very much knowledge of the specifics of those types of policies. I do know that it's been a problem that I've been able to fund family members to look after their elderly people. And I do think that one has to investigate that capacity, particularly in the more isolated areas.